Hi, everyone. My name is Dr. Koshi Jacob, and I'm a consultant radiologist who's worked in the National Health Service in the UK for a number of years. And I currently work for a few teleradiology companies. I am a director of Revise Radiology. I'm the CEO, a company that helps prepare radiologists for the FRCR exams. And we are set up in such a way that all our profits go to charities. And I think the first time, and Doctor, it's really my delight to introduce Dr. Rajagopal, who is a true luminary in the realm of palliative care. He is often referred to as the father of palliative care in India, and he also, as a result of that, he received the Padma Shri, which is one of India's top civilian. It is the highest civilian award in India in 2018 for his distinguished service. I came across Dr. Rajagopal when my father was in terminal care a few days before he died, and we were trying to make a decision about what kind of intervention to involve him. He had advanced dementia, and the doctors had given him an NG tube, and we were kind of deciding, you know, how long, where do we get the balance between prolonging life and enhancing quality of life, as we're against alleviating suffering. And speaking to Dr. Rajagopal was a life changer for us and for him. I believe he did, in the sense that he was able to die with dignity and comfortably, and also with with treatment that helped him go peacefully. And I'm really, really grateful to you, Dr. Rajagopal, for that work. Now, Dr. Rajagopal, his work has been rooted in compassion and a deep understanding of patients' experiences, which extends far beyond his clinical practice. He's been instrumental in advocating for policy changes at a national level, and improving access to palliative care education, fostering a holistic approach to healthcare that recognizes that the human being is beyond just a disease. There's a human being behind it, and that is what we signed up to when we gave the Hippocratic Oath, which is quite interesting because the film that has been made about Dr. Rajagopal is called the Hippocratic Oath. It was narrated by David Suchet, who many of you in the UK will know as Mr. Poirot. And interestingly, he's also a alumnus from the school that my children went to, Wellington School in Somerset, and so there's quite a bit of connection here. And just to say one more thing, Dr. Rajagopal is the founder chairman of Pallium India, which is a palliative care non-governmental organization that was formed in 2003, based in Kerala. And it is our pleasure in Revise Radiology to support his work. We are still trying to work out the mechanism by which we can do that. So it's my pleasure. Now, the film was called Hippocratic, 18 Experiments in Gently Shaking the World, and was released on World Palliative Care Day on the 14th of October, 2017. So, Dr. Rajagopal, it's interesting about the film, about the references to the Hippocratic Oath. The message of the oath is something that the healthcare seems to have strayed away from, in my opinion and in yours. For those who have not watched the film, could you summarize a little bit the message of the film and why people should watch it, and what brought you into palliative care in the first place?
Thank you, Dr. Koshi. Great privilege. This is an honor and privilege, particularly because we have a mission that was started a quarter of a century back and still in its infancy. Less than 4% of the needy in India, even now, get any palliative care. and misery is extreme. So thank you for giving visibility. About the film, it was conceived and created by a couple in Australia who run a film company. They make films for a living, but also along with that, they make films with the theme of palliative care, not as a profit-making venture, but as a service. So they conceived it. It evolved over many years, but during our conversations, I told him and his wife about how my life was influenced by Mahatma Gandhi. So he called the movie The Hippocratic, 18 Experiments in Gently Shaking the World. Those 18 key messages from Mahatma Gandhi are given the subtitles before each section of the film. Friends, I came into the palliative care because even as a medical student, I had the experience of watching a cousin suffering excruciating pain from cancer. And then as a medical student and as a young doctor, I went on seeing people in pain and suffering, but also something else, that the medical system was studiously avoiding seeing that suffering. Doctors and nurses were forced by circumstances to turn away from that suffering because there was no way they could cope if they confronted it. Then I became an anesthesiologist, started doing nerve blocks, and the patients taught me that they are not only made of nerves, that they are human beings with emotions. A British nurse by name Gilly Byrne, she still lives in England, introduced me to the science of palliative care. And then with a lot of colleagues, I started the movement. And it is an infant still, unfortunately, only Kerala, has only 3% of India's population. There is maybe 50% of Keralites who need palliative care get it, especially the poor. The rich people do not get it, even in Kerala. They continue to suffer in corporate hospitals where they're receiving no palliative care. But at least some people get it. But outside of Kerala, we are working in 24 of India's 29 states and in 2 union territories with a team of project coordinators. It is slow progress, but we are making progress.
So there you've mentioned something that was going to be my next question about healthcare. The fact that healthcare has become big business, and often at the expense of very, very poor people, but also expense of middle class and well-off people. So it doesn't seem to distinguish it. The only difference is that people who have money can have something left after it, whereas people who are poor, they end up in debt even after they die. Their families end up having to pay for medical treatment. And what role do you think, and that this is a specific question for radiology, what specific thing do you think radiology has had to play into families falling into debt and not having money to pay for the treatment that they need? And I realize, radiology with its very expensive treatments can be expensive investigations can be crucial to find out what's wrong. But sometimes it's knowing the balance between finding out and keeping people comfortable and giving them palliative care. Do you have something you can say about that, Dr. Rajagopal?
Thank you. Yes, indeed. About the first point, you are very right. The middle class are driven below poverty line. And if you would like some data, it appeared in a Lancet publication. The numbers in 2015 of people driven below poverty line by catastrophic health expenditure. Take your wildest guess. It was 55 million Indians.
Wow. 55.
I have the reference. You listen, this is happening all around us. We just refuse to see it. And the very poor are subjected to another issue. You asked about radiology. It's unfair to talk about radiology being a problem. It's about medical science as a whole. We learned from Western countries. We practice what we learned. Our doctors come to UK, learn all the latest technology, import the equipment, and practice everything. We don't interestingly import your social workers. We bring only the technology and the expensive things. So what really happens is the medical system, instead of discussing what should ethically be done, just says, get the scan done. How can I treat you if I don't know what you have? Easy. That means a huge chunk of the population, certainly at least 1/3 of the population, are denied any health care. After they have spent some money, they are told, do a scan and come back, and they won't go back because they can't afford it. This is the reality. That's one major part of the problem. The other problem also, it's not only radiology. Till now, till 2019, communication was not something taught to medical students. Once I asked a group of medical students, tell me your experience as a patient or as a family with the healthcare system, either good or bad. One girl stood up and she was very angry and said, it's not as a patient or a family member, it was as a medical student. I was there in the radiology room. The sonogram was done, and the sonologist just said, the fetus is not viable. And there was this expectant mother on the table having a bombshell over her with no warning at all, no preparation.
The lack of empathy and compassion.
It is not only, empathy. And also the problem is it was never discussed in classrooms. Things have changed. From 2019, it is in MBBS curriculum, communication. But how many, it will take a quarter of a century before that gets into practice. Sorry if I haven't answered your question.
No, you have answered the question. But, many of us, I studied in the Christian Medical College in Vellore, which you probably know about. It's dedicated to compassion and treating people with dignity. And we joined medical school with noble visions of helping patients. But we do get discouraged later, or at some stage, corruption enters in, where the health system is so commercial and the vision starts to fade, and suddenly you're in a situation where you may be working in a scan center, and you either get a commission for the whole commission structure. You got the doctors send the patient for a scan, and then the scan center pays them a commission for sending, and it creates this whole corruption in the medical sector, which really saddens me when I see how it, especially in India, but I'm sure it happens in many parts of the world. In the NHS, it doesn't work like that so much, at least not at that level, but there's certainly incentivization happening. So how can doctors sustain their initial vision and fight for change and fight for change in that area?
Uh,
I know it's a very difficult question, but
you will consider me a palliative care fanatic to say for saying this, but really I believe what the introduction of palliative care into MBBS curriculum has done is to bring humanity in. I worked for a long time in Calicut Medical College, where I started palliative care. There would be 200 medical students. Every year in those years, at least 20 would get trained in palliative care and a whole course, 6 weeks course afterwards. And many would stick into palliative care. As you mentioned in the beginning, there are so many people who come in with a passion and empathy, but they are taken out of them because there is no other way. When we show them another way, I'm sure many will follow. I see it already happening in Kerala, but I can see it in the future happening elsewhere also. They need a path to be shown, and many will follow it. Not all, I know,
yeah.
Many will.
So one of the things that we've been, when we go through radiology specialist training, one of the things that I've often noticed is a patient comes in terminal care, and the physician in the A&E department or general asks for a CT scan. The patient is dying, and the question gets raised: what role can radiology play in helping people die with dignity, or rather not play? Because every radiology examination can be uncomfortable. It's an additional trauma for the patient who is coming to the end of their life, having to deal. And of course, we in the UK, we call ourselves clinical radiologists. So we are not just technicians. We are meant to be part of the clinical decision making, which is why a lot of us come from a clinical background. I did medicine, I did MRCP before I did radiology. So you get a lot of those communication skills then. But in terms of radiology helping with palliative care, could you tell us a little bit around that and how we can foster an empathetic approach?
Thank you for the very important question. It's not only for the radiologist, whatever be the specialty. Essentially, we are all doctors. And all doctors are also human beings, and sometimes we forget that. But as doctors, in India, the duty of the healthcare provider is defined officially by the bioethics unit of ICMR. The duty of the healthcare provider is to mitigate suffering. There exists no exception to this rule. No, that's important for anesthetist, palliative care physician, radiologist to remember that essentially our duty of care to the patient is to mitigate suffering. And in that final day of life, they shouldn't die alone outside the radiology room. They should be surrounded by the family, giving love and receiving love, being able to convey a final message. And sometimes I think it is important for any clinician, including the radiologist, to be able to stand up and say, look, this is just not done. What's the point? We cannot satisfy your academic clinical curiosity at the expense of the welfare of a human being.
Yeah, absolutely. I absolutely agree with this. And this is the kind of empathetic approach that we must foster in radiology. Now, when we met last week, which was a real pleasure, You mentioned that palliative care in India needs to be different to what is practiced in the West, especially when it regards in the UK, for example. It's very palliative care is often around end of life and pain relief. But you mentioned about other conditions and how your organization deals with other long-term conditions. And I think the definition, I've spoken to many, family members who have, parents maybe with dementia and other conditions. And if you even mention the thought that, perhaps you should have a chat with a palliative consultant, medicine consultant, it's kind of, no, that's for cancer. That's for end of life. Can you elaborate a little bit about the difference or how palliative care in India may be different to what we have in the UK?
So if, the WHO definition is 21 years old and is about a mile long. But we go by the simple definition. Palliative care is mitigation of serious health-related suffering. Now, what conditions cause serious health-related suffering? That would be very different between the UK and the rest of the high-income world, which is mostly Euro-American countries. And 85% of the world, Dr. Koshi, it is not only about India. It's about all low and middle income countries where healthcare, including primary care, is suboptimal. So tell me, what should I do when a person following a stroke or a spinal cord injury is lying there with huge pressure sores, with recurrent urinary infections, shut up inside 4 walls for 3 years, and dying a slow, painful death? What kind of doctors are we if we walk away because a paraplegia does not warrant palliative care in the UK? The cause of the serious health-related suffering is a wider range of disease conditions. Yeah. So we include frailty of old age, we include chronic pain, yes. We include paraplegia and hemiplegia following a stroke. So it is not the diagnosis. The diagnosis might be different. And the most illustrative, just more like a question than a statement, was asked by a Ugandan nurse who was confronted, palliative care nurse working in the field, was confronted with a woman in obstructed labor and took her to a hospital. And her boss said, why? That's not your job. You are supposed to do palliative care. And she says, I am from that community. If I find somebody in suffering, I don't care about your definition. I'm not going to walk away. I think that nurse, whose name I do not know, would be a guru. So many of these conditions causing suffering is what we look after. That means the gap between the UK and India in access to primary care would increase the demand for palliative care. And then somebody may ask me, but palliative care is not the answer. The answer is improving healthcare. I agree. Yes, but till then, for the next quarter of a century, sorry, I am not prepared to walk away.
Yeah, I think that is, and the fact is that in the UK, while palliative care looks after a particular aspect of a patient's care, there is a wider, you mentioned about social services, you mentioned about, probably rehab services. All that is dealt with, and there's a bit of a holistic approach. But what does Pallium India do? How does Pallium India do a little bit? The bit they can in Trivandrum and around those areas in Kerala to bridge the gap in palliative care. And you also have a few centers around the country. Tell us a little bit about Pallium India and what you're doing.
We call it DEF model, demonstrate, educate, and facilitate. In Trivandrum, where we at any point of time look after something like 4,000 to 4,500 patients with 7 home visit teams, outpatient, multiple outpatient clinics, etc. Here we demonstrate palliative care so that students and trainees can learn from that. But we do multiple courses. If you go to our website and look at the link for training, you will see that we run about a dozen different courses, many of them virtual, educating healthcare providers in palliative care and facilitation. We have a team of project officers and coordinators headed by one person with headquarters in Trivandrum, but others are in different zones who work with the government, local state government, the National Health Mission State Office, and with the hospitals, with the individuals who want to start palliative care and empower them and enable them. So between the demonstration in Trivandrum, education across the country, and facilitation team facilitating development across the country, we hope to reach 10 million people in 10 years. That's our goal.
That's an ambitious and fantastic goal. How do you think, this is sort of the final question in a way, how do you think we as a organization, Revised Radiology, can help Pallium India towards its goals and ambitions?
About the third edition of the Oxford textbook carried a quote. We are citizens of one world. We all have a joint future or none. I believe we should be working towards the needless relief from the serious suffering. And as radiologists, not only as radiologists, but as human beings also, there's a lot that we can do, like including, somebody, Dr. Koshi, you came across palliative care in Kerala through a family member, but others may have a cousin, somebody. Maybe you can just facilitate access to palliative care for them. We also have a telehealth team which works at the national level. It will be a privilege for us to support anybody who needs help. Secondly, of course, we need resources. And what you spend on a cup of coffee, you can imagine what difference it will make to somebody. Feed them for a whole month here in the poor, among the poor people in the villages, but also being advocates. How many centuries back, Rodolphe Virchow said, physicians are the natural attorneys of the poor. Please talk about palliative care. Please talk about relief from suffering. And Dr. Koshi, Revised Radiology. Sometime in the next year or so, I hope you will consider coming out with a position statement and as a recommendation for all people interested in radiology, especially in the low and middle income world. Importance of the ethics of it, about the way in which our practice can cause suffering, and how to avoid falling into that trap. But you are already helping, and I thank you very much for that. And that is not only the money, it is so strengthening to feel that so many people are behind us.
Yeah.
Thank you for doing that.
I thank you very much also. And as we draw this conversation to a close, I want to really thank you, Dr. Rajagopal, for sharing your insights and experience with us. I would really recommend that anyone who hasn't watched the film, watch it. It's Hippocratic. It's available to buy on Vimeo, and we will share the link to buy. It's a very small contribution to watch it. and I think you'll really be inspired by it. Now, we've delved into the intersection of radiology and palliative care, a topic that is sort of seldom explored, but holds a great deal of significance, I think. We've also discussed today the challenges, I believe the opportunities, and the immense potential that lies in recognizing and addressing the needs of patients beyond their physical ailments, treating them as human beings, and ensuring their dignity in all stages of their healthcare journey, especially alleviation of suffering. So the onus is, I believe, is now on us, the healthcare providers, to continue this dialogue, to learn from one another, to strive for an integrated approach that truly serves the best interests of our patients. So thank you once again, Dr. Rajagopal, for your time and for the work you do. It's been an honor to have this conversation with you, and we look forward to continuing this dialogue and turning these insights into actions. Thank you very much.
Thank you very much for all the support, Dr. Koshi. I look forward to our work together.
Thank you.